Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, and I am here today with my jungle-friendly co-host, Dr. Millicent Rovelo, looking very sort of set up for a jungle safari.
You know what? That's what I was feeling too. I'm wearing my jungle safari dress, and then I come into this podcast studio and we have the green lights and we have the plants, and it's 85 degrees in here because the air conditioning is not working.
There's no air conditioning and we are sweating it out.
Sweating, and I love it. I'm like, I feel like I'm in the jungles and the humidity, and it's right up my alley. But that's not why we're here today.
Well, it's either that or the summers in New Jersey, which are also the same way. No, we're here to talk about revision rhinoplasty, and
Yes.
This is something I do a lot of.
Yes, you are the revision guy.
And judging by my numbers, which Dr. Safran has been analyzing, our fellow, I'm doing an awful lot of revision rhinoplasty on some really difficult cases that come in.
Right. So revision rhinoplasty, these are patients that have had previous rhinoplasties and for whatever reason are not happy with their results or the outcomes, and they're coming in to have it revised. And these are patients that have had one previous rhinoplasty, two previous rhinoplasties, 3, 4, 5, keep going, 7, 8.
Yeah, there's a limit. You sound like the Margarita song there. I had one rhinoplasty, I'm going to get a revision. Yeah, I mean, there is a limit to it, but these are people that have had revision. They've had rhinoplasty somewhere else, and now they're seeking an expert who does revision rhinoplasty. And there are, a lot of plastic surgeons do revision rhinoplasty. Especially if you're going to do rhinoplasty as a primary operation, you kind of got to be able to revise your own.
Yes.
Because the statistic is 15% revisions of rhinoplasties, all comers. Mm-hmm. And I think it's actually higher than that. But that's the stat that's published, and you can kind of rely on that. And 15% is a real number.
That's a real number. And not all of the revisions are big undertakings. No. I don't know what exactly constitutes a revision for those numbers, if it's a return to the OR or if it's anything done under local, because it can range. It can be something small, like a little local procedure, adjust this, adjust that, or it can be like the full deal.
I count it all. If I have to revise my own work, whether it's like giving some local anesthesia and trimming a caudal septum or something like that, I count that as a revision. So in my stats, when I tell people my revision rate on primary rhinoplasties between 5 and 10%, and if there's been trauma, it's 10 to 15%, and if you've had rhinoplasty somewhere else, it is 15%. I know those stats based on what I do. I think that revision rhinoplasty in the setting we're talking about is you've had rhinoplasty somewhere else, you've gone back to the surgeon that did it, they said, I'm not really comfortable, you need to seek a revision specialist. That's who I'm seeing.
Yeah. So these are a little more high-level, high-tiered, or patients that just are unhappy for whatever reason with their results and their surgeon. And do you feel like your patients are coming to you because they don't like the aesthetics, or they don't like the function of the nose, or a blend of the two?
It's typically the aesthetics that gets them to me, but there's a very, large percentage that have functional problems also. A nose is one of those organs that it needs to look right to work right. So that's kind of the thing. Yeah. Like a hand is the same thing. Right. Like if your hand doesn't look like this, if it's gnarled and mangled, it's probably not going to work right too.
Right. It's a functional organ.
It is. So your nose needs to look right in order to work right. If it's twisted, turned too far down or too far up, the airflow is going to be compromised. But typically the patient this is my typical scenario. I've had 2 rhinoplasties by the same surgeon, or I've had 1 rhinoplasty by a surgeon, then gone somewhere else, and now they're seeking me because they're past the point where they go, I'm confident with the people that I've seen. They've lost confidence and they want to go to somebody that is known to do revisions, which I do a lot of, and there are a very, very large percentage of those cases that I can help. But, not everybody can get a revision rhinoplasty. There are some patients that are too far off the spectrum, and it's not going to help. And you're talking about having to do forehead flaps and things that are just unreasonable. But
right.
But that's the rare case.
That's rare.
Yeah.
And do you feel like there is a classic set of complaints that patients have about the aesthetics, or does it run the gamut? Or do you see usually they say this?
Well, it depends on the ethnicity of the patient. And that's why if you go back and shuffle through our podcast library, which is now coming up on 250 episodes soon, we have a Asian revision rhinoplasty. We have, ethnic revision. Like there's all these different versions of revision rhinoplasty because they all have their nuances and their sort of specialty factors that you have to kind of know about. And so for me, it depends on the ethnic background of the patient, and it depends on what was done. So if they're, not happy with the way the tip looks or the bridge or it's twisted or it's just not cute, which, is the typical sort of complaints. Like I went for a rhinoplasty, but this isn't what I had in mind at all. And they'll typically show me some imaging that, is amazing. The imaging is always so good.
Yeah,
it's
the 3D.
I'm terrible at that. I suck at doing the imaging. That's why I draw. And by the way, I think doing imaging in revision rhinoplasty is definitely not helpful because you don't have that kind of control in revision rhinoplasty. I think my drawings are much better. They're better representation of what I think is possible because I see the nose, I know it's in my brain that I can do, I know what graphs I can use, and then I can represent it in a drawing much more effectively than I can with a 3D imaging program that has massive levels of constraints that doesn't allow you to show what a reconstructed nose would look like. But that's another podcast altogether. That's another podcast.
There we go.
So we'll do that one. But anyway, the revision rhinoplasty, typically these people are going to understand that their cartilage has been taken from their septum. They're going to understand that maybe some ear cartilage has been taken, and they know that they're coming to me, which means that I'm probably going to be using rib cartilage to reconstruct their nose.
Yes, and that is sort of a cornerstone of revision rhinoplasty, at least how you do it, because most of the time, yes, the native cartilage that was in the nose that you would otherwise use for the grafts has been harvested already with the first rhinoplasty or the second rhinoplasty. And by the time you get into your second, third rhinoplasty, you really need support and structure in the nose. And flimsy little ear cartilage is not going to cut it, whereas rib cartilage is nice. That's going to really give you a nice, strong graft.
Yeah, and that's what you need. You need good material because what we're talking about is there's two big components to generating the result in revision rhinoplasty. One is getting control of the cartilage and bony framework. And a lot of times it is out of control, and that's why the result has been poor. The septal L strut, the cartilage that's left behind after doing a septoplasty where you take the cartilage from in between the nostrils to make grafts for the nose, oftentimes is very flimsy. It might be 5 millimeters, 6 millimeters, when really it needs to be 10, 11, 12 millimeters. So it's weak. There may be a saddle nose where literally it looks like you could sit on the middle vault of the nose and ride it like a saddle. So hence the name.
So it's lacking support. It needs some nice, robust support.
And you gotta get some rib.
So how does a rib harvest work? Just briefly.
Small incision. I like the 8th rib. Everybody's got their favorite rib. My buddy Nazım Turkish in Turkey likes the 7th rib. Some people like the 9th rib. I like the 8th rib. It gives me lots of cartilage. It's, they're always, the argument against it is like, oh, it's always calcified. It's never calcified. So I've had two really calcified ribs, and they were on young people. I just did a revision rhinoplasty on a 68-year-old woman. Her rib was perfect. And I said, if I'm going to go take your rib, if it's calcified, I'll use a cadaver rib. And a lot of people have just gone to cadaver rib because they're so readily available. But to me, they're two different materials. It's like if I have the patient's own rib, it's like having the I-beams and an amazing 2x4s to build the house with. And if I have cadaver rib, it's like having like some, maybe double-weighted corrugated cardboard. They're different. They're different.
Yeah.
And you can do it. It's not like if the patient says to me, no offense, I'm 68 years old, I don't want to use my rib, please use a cadaver rib. I'll do it because at 68, it's not a big deal.
It's not a big deal. And the incision is small. It's right over the ribs. And you go down there, you harvest what you need to, take a little, several centimeters of rib, close it back up. You have a little skin incision. It's sore. It's a little tender and sore for, several days, a week.
Yeah, it's not terrible.
But at the end of the day, the incision's very tiny. You're never going to miss that piece of rib. But what it can do for you in the nose is incredible.
Yeah, you need the structure. And everybody worries about pneumothorax, like, oh, what are the chances of getting a pneumothorax? I've had 2 in my entire career. No big deal. We suctioned them out, close it up. It's nothing. If the patient's asymptomatic, then they're off and running. But it is such a great material. So the 2 things I was getting at: 1, building the cartilage bony framework, and 2, controlling the soft tissue. And this is the big miss in revision rhinoplasty, is that the soft tissue envelope can scar in. It can cause all kinds of movement of your cartilage grafts. It can change things in a way that you get unfavorable results. And my job is to anticipate those things. I'm very good at it, but I'm not perfect, which is why I always say that if you're going to sign up for revision rhinoplasty, then you must see it as a project, not as a one-off. This is not like getting a breast reduction or a breast augmentation or a facelift. Those are one-offs. You go in, you get the operation, and it's over. A revision rhinoplasty, I work at these things. I really spend time trying to manage the soft tissue envelope, trying to get things to cooperate. I watch them like a hawk. This is why it's more expensive. It's more visits, it's more care, the degree of difficulty is through the roof. Most surgeons don't want to touch these cases, which they're the smart ones.
Yeah.
I got into I don't know, somebody that's right. The genius Dr. Rovelo went, yeah,
no.
That's not for me. I'd have somebody in the office who can take care of that for you, and goodbye. But it is, I'm very passionate about it. Obviously, I work very hard for my patients. I'm not perfect. The operations are not perfect. They are all on a spectrum of shades of success. And as a patient, if you're listening to this and you're thinking, I wonder if I should do a revision rhinoplasty, here's the question. Can you live with the nose you have now? If you can live with the nose that you have now and you're good for the rest of your life, then you don't need to have a revision rhinoplasty. But if that rhinoplasty that you've had weighs on you and it's in your head and it takes your confidence away and it's hurtful to you, then you should explore a revision rhinoplasty with an expert. In my world, there are 10, 12, maybe 15 experts around the world that I really see as people that are going to give you the best shot that you can possibly get to get this right. And then there are lots of other surgeons that will do revision rhinoplasty. And then if you're going to those folks, then just figure out whether they've got the plan and they can do it for you. But in my world, this is a highly specialized field. It's just not something you want to play around with. And if you want to get it done right and stack the cards in your favor, make sure you're going to one of those experts. And they're on lists. You can find them. But it doesn't mean you're going to get a great operation. Like, your situation may be one that's really tough.
Yeah, it very much depends on what you come with and bring to the table. So how much damage there is in the nose, how much trauma there is, what there is to work with. And even in the best situations, as you alluded to, even in the best hands, the healing process itself can be unpredictable. And I know you do everything you can to predict and to foresee what those forces may be in the future and adjust accordingly in your surgical plan. But even still, the nose that has been traumatized by actual trauma or by previous surgeries is going to scar and heal in sometimes unpredictable ways or ways that you don't want it to. And so that's where the process comes in, and the understanding that you have to have that you may need another revision after this revision, but hopefully that second revision is to a much smaller degree.
100%. And that's why I say it's a project, because we're going to work at it for a year. And you got to hear that. And, we've done other versions of this podcast, and if you want to go back and listen to those, you certainly can. One of my patients even noted in one of those versions that I said that the process sucked 3 times in the podcast. He's like,
so you're
I noticed that it sucks. And I was like, it's a tough process. It's not for everyone. But, I have to say that it sucks a lot less than when I said that, because now I'm doing a lot of things about the soft tissue reconstruction that have altered my results pretty significantly. I'm doing a lot of framework suturing, ligamentous reconstructions, removal of scar tissue pretty aggressively in the very thick, burnt out, scarred in, thick skin noses that need revision. I'm doing some stuff that have changed the course. I'm much more optimistic about the soft tissue management. And if you go back and listen to those podcasts, you'll hear that I said the future of revision rhinoplasty, what's going to radically alter the results is soft tissue management. And I have been working at that since I've said those words. And it is changing the game. So I do feel that there is a brighter future in revision rhinoplasty. Obviously, the best way to manage your revision rhinoplasty is to never get one and go to one of the experts and get a good primary.
But if you're listening to this podcast, chances are it's too late for that advice.
I know.
So you're here and you're getting your revision. And let's talk a little bit about the recovery process, because it's going to be a little bit different than from the first go round, right?
Yes.
So the first go round, you have your rhinoplasty, you have your splints on for a week, you take them off, some high fives, you wait for the swelling to go down, and in a few months, you have this pretty nose and you're walking around with it. With the revision, take that timeline and double it. And if it's your third surgery, triple it, because all of those time markers are going to be extended.
They are. And that's why I recommend hyperbaric oxygen, which we have a whole hyperbaric oxygen episode as well. But hyperbaric oxygen, basically you go to a facility that does these hyperbaric chambers. They put you in the chamber. They pressurize it to 1.5 atmospheres with a higher oxygen tension. That's normally used for wound healing and things like diabetic ulcers and radiation damage to tissues. Well, in revision rhinoplasty and facelifts and things, it causes the healing to be faster and it gets the swelling down faster.
A lot faster, because that's usually what it is. I mean, the pain is there and the splints will still come off in a week, more or less, but it's the swelling that's really going to persist a lot longer and really just prolong that final result that you're looking for. So you have to be in it. You have to know that you're not going to see that pretty nose you wanted for like 6 months, 7 months, 8 months, a year. It takes a long time for that swelling to go down. So you just have to know that and be patient.
And, again, I post this stuff on my social media constantly. Here's a, 3-month, revision rhinoplasty. I want everybody to know what they're signing up for. Like there is no, you need the information. You have to understand what you're getting into because you have like a life to live if you're going to do this. You have to go to work. You have to face people. You have to, for whatever reason, I have, more lawyers as patients than any other, section of this population. If anybody needs a good lawyer, I can give you one for anything because they're all my patients. And they all come to me with like, how do I get back into face-to-face meetings? And this is the big thing because if you're a lawyer, I mean, unless you're doing like tax law or something like that, most of my lawyers are either in the courtroom or they're in some sort of proceedings that they're face-to-face, and their income requires them to feel confident to do well for their clients and to look like normal people. So like getting back into the being able to be quote unquote on camera for whatever it is that your job is really important. So when designing these revision rhinoplasties, like I take the lifestyle of the patient into consideration in a big way. I don't want anybody to be ambushed with what they're about to sign up for. And so this is where the transparency and the information that you need to decide if this is for you is really key.
Yeah, great. I couldn't agree more.
I mean, that's kind of everything with all plastic surgery. You want to know what you're getting into. It's really important. But I would just say for those of you that are thinking about a revision or that have gone through it and now you're hearing this podcast, like stay with it. Believe in your revision surgeon that you hired to do this with you, and understand that it is a project, and things come up. They really do. As good as any of the experts are that do this, we all have issues with it. It's all there. There are problems that we try to anticipate everything, but sometimes stuff just raises its head, and you're like, dang it. Well, this is what we need to do. And I'm very quick to be like, this is what I need to do. Because usually the fix, if the operation was done well, the fix is usually pretty simple. There are things that you can do to kind of get things back on track, but they do require you to lay down, hold still, have some kind of like local anesthesia or possibly back to the operating room and heal it. And so it sucks. That's the part that's really hard.
There it is.
It does.
But just the once. Just the one
Okay,
time.
just once this time. But I think that's about it. I think look at the before and afters. As we say every podcast, the best way to pick your surgeon is look at the before and afters. Make sure that you like the results, and then get in the office and get a consultation, because until you talk to the surgeon, you're not going to know what's really possible. Like DMs back and forth on social media isn't the way to do
Nope.
it. Talking to the office staff, they know generally what their surgeon does, but they don't know the in and outs and the details of what needs to happen.
Yes, sir. I think you got it.
Well, good. In that case, this is the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.